But if I may, Thanos, say, as you look across the subgroups, in other words, one prior line and longer, how do you see mezigdomide-based therapy being placed as a result of Successor-2?
Yeah, I believe that there are practices around the world where physicians are not so keen to have their patients exposed to the unknown for them toxicity of bispecifics with opportunistic infections. And I believe that there will be patients who actually will be treated with this regimen as a second line.
Right.
It's oral regimen. Of course, you have to receive the IV calfizomib, but after a year for responding patients, this is be given twice a month. You know, physicians are very well accustomed, hematologists and oncologists in the United States, with the use, with the treatment of neutropenia, and you know, you do not have the anxiety of these opportunistic infections. However, as Rahul mentioned, there will be several patients who would be treated with T-cell redirecting therapies. At a certain point, the disease will progress, and this is a perfect combination not only to induce long-term disease control, but also to work as a bridge for a potential another anti-BCMA therapy. And finally, there will be studies with bispecifics based on the T-cell exhaustion reversal, quote unquote. Why not with antibody-drug conjugates, such as with belantamab mafodotin, and you know, other regimens that would be or drugs, since this is a drug that has a distinct mechanism of action, is not dependent on T-cell function.
Yeah, I think it's very well put. I'm particularly excited actually about the opportunity with belantamab because, of course, we have the success of DREAM8, and we know that Bela-Pomdex works extremely well, especially in high risk. You know, let's look forward to what we can do with Belamezi, especially with its true off-the-shelf capability. Katja, as you think about the positioning of mezigdomide-based therapy, do you have additional comments to add to Thanos?
I fully agree. I think BCMA and anti-BCMA strategies will clearly move in front, but we need also alternative salvage regimens. And I think this will be also a regimen which can be very well used as a bridging strategy, as you said already, sandwich between T-cell engaging treatments. So to restore also T-cell function, to enable a better T-cell fitness. And I think there's more to come. We will see more data and more combinations. But it's now a regimen which was investigated in the current landscape of treatment in myeloma. And I think there will be many places where to position it in the field.
No, I can completely agree. We use the term, you know, it's the cell mod for all seasons. You can put it right across the whole spectrum. So I 100% agree with you. And if I may, Rahul, one point to sort of build on, which, because I know we're doing the mezigdomide selinexor trial together, for example, which is purpose-built to rejuvenate and turn around immune exhaustion. As we think of that, and we think of also for the fact, actually, the very simple fact that in Successor-2, the median PFS for those in first relapse has not been reached. As you look to the future, how do you think in your practice in Washington, in Seattle, how are you going to use Mezi?
Yeah, absolutely. So I would love to use it at first relapse for a substantial amount of patients. You know, I think it's already a complicated landscape with CAR-T, and you know, Tecdara in the U.S. is already available, will be available in Europe soon. You know, talquetamab-based combinations that may become available. I do think every one of them has their flaws. They're all excellent treatment modalities, but with CAR-T, the logistics are very complicated for patients. For Tecdara, it's a great regimen, but the infection piece, as all of you alluded to, is a big challenge. And even if IVIG or intravenous immunoglobulin or immunoglobulin replacement mitigates that risk, that is a substantial amount of time in clinic. Mezi-KD, as you alluded to, such a low infection profile, and then the only reason you need to come into clinic is for the carfilzomib, so to speak, right? And now the carfilzomib gets dropped or de-escalated, Mezi is an oral regimen. People love oral regimens. So I think there'll be obviously shared decision-making in this, but I think for a lot of patients who I'm a little nervous about bispecific antibodies, or just logistically it just does not make sense for them to get a bispecific antibody or CAR-T, Mezi-KD is very easy. And in community-based practices, I suspect will be a lot of uptake here because they're very familiar with carfilzomib, as Katja alluded to. Mezi, the side effect profile, the supportive care, GCSF, we know how to handle. VTE prophylaxis, we know how to handle. Exactly. So I think there'll be a lot of usage in those particular patients, and I'm fine with that. And if they don't like it and want to move on to CAR T therapy later, they'll be debulked. But I think many of them will want to stay on treatment, hang around for those 18 months PFS, likely longer at first relapse, and go from there.
No, I agree. It's an extremely good point you make about the infectious issue, because the rates of complex infections or opportunistic infections are very low, which is very important to understand, because as we look at the data across studies, sometimes I think we're a little bit foxed by grade 3, 4 incidence of infections, which is fine, but there is, as Thanos and I were discussing the other day, there's a fundamental difference between CMV retinitis that may be scored as grade 3 and an upper respiratory tract infection that just requires a course of augmentin after a single shot of ceftriaxone. So I think as we think about that, it's a very good point you make about the complexity of infections. I think another flip of this, which is...